The purpose of this podcast is simple. We want you to get to know your doctor before meeting them in person, because you're making a life-changing decision and time is scarce. The more you can learn about who your doctor is before you meet them, the better that first meeting will be. There's no substitute for an in-person appointment, but we hope this comes close. I'm your host, Eva Shea, and you're listening to Meet the Doctor. Welcome to Meet the Doctor. Today, my guest is Taylor DeBusk. He's a facial plastic surgeon, and he lives in Houston, Texas right now. Good morning, Dr. DeBusk.
Good morning. Thanks for having me.
Why don't you tell us about yourself? That's usually the best place to start.
Yeah, I am originally from Denton, Texas. I went to LSU for undergrad, go Tigers. Stayed down there for med school and then trained kind of all over the country, up in Minnesota and California. Now I'm back in Houston, Texas. This is where my wife is from, so I didn't have much of a choice on where we were going to end up. We have two sons. My oldest son, Liam, is almost 3. My youngest son, Levi, is almost 5 months. And we are loving Houston, Texas, the heat and all.
Yeah, it's a great place to be. I totally agree. When I moved to Houston for the first time, that was 1998. I remember waiting all year for the season to change. The whole year went by.
Yeah.
And it never did. It took so long for me to get used to that difference.
Well, that's what I tell everybody here. There's 2 seasons, hot and really hot.
That's right. You forgot muggy.
Yeah.
So Minnesota, what did you like about Minnesota and what didn't you like about Minnesota?
Well, didn't like is easy, and that's the winter. And you're from Minnesota, nobody likes the winter up there. Everybody complains about it. It's long, it's cold, it's dark. But as soon as it gets down to 40 degrees, everybody's out in shorts, flip-flops, and tank tops. Yeah. Oh, yeah. And I loved, everybody out there just takes advantage of the good weather. As soon as, the sun comes out, everybody's outside, biking, hiking. They're never indoors. And they're a resilient bunch up there, those Minnesotans. I loved, again, the seasons. Minnesota is a special place for my family because my wife and I got married when we were up there. We had our first son in Minnesota. So it's a place we still call home.
It's a good place to be, and it's a good place to train. So I kind of stalked you online a little bit just to kind of get a feel for what you were doing and where you were. And I saw something I don't usually see, which is microvascular reconstruction of the head and neck. So I have kind of 2 questions there. One is, what even is microvascular reconstruction if you've never heard that before? And then how would you train to learn to do that thing?
Yeah, so microvascular surgery, specifically to the head and neck, we use a lot in head and neck surgery when we're rebuilding defects after cancer resections. So if you have to remove a large part of the jaw, you can take the bone and soft tissue from the lower leg along with the artery and vein or the blood vessels, and then hook the blood vessels up to those in the neck so you have vascularized tissue when you're rebuilding the jaw or large defects of the face or oral cavity. There's several different routes of training to establish those skill sets. Within ENT or head and neck surgery, people don't realize that the large portion of ENT training is head and neck cancer, both the resection or removal of the cancer as well as the reconstruction. So I spent 5 years in Minnesota largely just doing head and neck cancer, both cutting it out or removing it, as well as reconstructing, along with a lot of the facial plastic surgery, both aesthetics as well as reconstructive.
Is that mostly an older patient base, or did you find yourself taking care of younger people too?
It's a combination. I've done microvascular surgery or reconstructive surgery in patients as young as 3 years old up to 98 years old. So it's a broad spectrum because there's a lot of tumors in the head and neck that aren't necessarily cancer, but that do need to be removed. So you get a pretty good, well-rounded experience from the reconstructive standpoint.
So this is probably a really dumb question, but when you see microvascular, does that sort of also mean microscope, as in you're using a microscope when you're reattaching these tiny blood vessels?
Oh yeah, yeah, definitely. So we use the microscope and we use very, very small suture, smaller than that of the diameter of a hair, to sew the arteries and the veins and the nerves together. I also do facial reanimation surgery or patients that have paralysis of the face, whether that's from Bell's palsy, from tumor resections, from Ramsay Hunt. So a lot of patients that develop either complete paralysis of the face or partial paralysis, there's a lot of different techniques, both minimally invasive and then large microvascular surgery to help give them function of the face again. So there we sew nerves together, again, using microvascular suture.
So something like Bell's palsy, I thought usually went away on its own. Are there people where that doesn't occur? It just sticks around?
It can. A large portion, the vast majority of patients with Bell's palsy will regain total function of the face. But there is a subset population of those patients that develop either some residual facial paralysis, and then as the nerves try to regrow, they regrow in an abnormal position. So they get involuntary contraction of some of the muscles of the face. It's called synkinesis. You can use things such as Botox to help give people facial symmetry to relax some of those contracted muscles. And then there's an even smaller subset of Bell's palsy patients that have complete paralysis of the face. And then we're talking about doing things to rewire some of the nerves to give them their smile, or even put or do a microvascular or free tissue transfer to help regain total smile function. It's a lot.
It sounds like a very high tech specialty, when you're taking someone's face apart and putting it back together for
Mhm.
them. What kinds of interesting things are happening on that sort of technology horizon in that area?
Yeah, so facial nerve in general, reanimation or management of facial asymmetries is really kind of the big thing in facial plastic surgery from a reconstructive standpoint. There's a lot of strides and have been a lot of strides within the past 10 plus years in regaining function. Again, from static things to just make patients' faces look symmetric at rest to dynamic, meaning that you can give them a functioning smile. A lot of research out right now or investigation into really regrowing those nerves to allow patients to regain the function of the face without having to undergo any major invasive procedure. Right now, depending on the degree of paralysis, that dictates kind of the invasiveness. But in the future, hopefully, we can regain those nerves without having to undergo large surgical procedures.
Yeah, I can see how that would be helpful. So, how does this kind of training, do you think, help when you're approaching a cosmetic procedure?
Yes, and I get that question from patients and a lot. So my head and neck surgery training, whenever we are, taking out cancers, reconstructing faces, you have to have a very fine understanding of the anatomy of the face, from skin all the way down to the nerves, to the bones, to the blood vessels. So when we're doing or looking at somebody's face from an aesthetic or cosmetic standpoint, number one, I'm extremely comfortable with the anatomy of the face, given my background. And number two, when you reconstruct the face, you always have to take into account the cosmesis because you want to make sure that the patient looks as normal and can function in society as they did prior to removal of any sort of facial cancers or anything like that. So aesthetics has always been a part of my training and my experience. Now, when we go to purely aesthetics, again, my understanding and comfort with all tissue planes of the face really kind of gives me that advantage or that edge.
Yeah, it completely makes sense. You would not just flip a switch one day and say, "Now I'm going to make someone's face pretty too."
Yeah.
If you're reconstructing someone's face, you're always doing aesthetics, whether so it's the reason that changes and not necessarily the way that you approach it. Noses are also really complicated and scary. And I mean, for patients, maybe not for
Mhm.
you. How did you train? to do rhinoplasty and what was involved in that training?
Yeah. So, as again, my ENT or head and neck surgery background, we were operating on noses from my first day in residency, doing septoplasties, things on the inside of the nose. So, we had a very fundamental understanding of the entire anatomy from a functional standpoint early on in training. Then, in our residency, my specific residency up in Minnesota, it's a very high volume facial plastic experience. So we did a lot of functional cosmetic rhinoplasty as well as cleft lip or palate rhinoplasty. So again, that's a rhinoplasty in kids, 2 years, 1 year old, all the way up to patients, 80 plus. So we had a very high volume experience in our residency, did probably 200 rhinoplasties and then have done several hundred since then. So my understanding is pretty sound of the nose, of the anatomy. And then the ability to manipulate that anatomy to give you that aesthetic or your cosmetic goal. Now that's a whole nother level, which I love and enjoy because you have, number one, you have to know the anatomy. And then number two, you have to know how to manipulate the contour of the cartilage to give you that desired outcome.
Let's say you're just hanging out with your 2-year-old and they do the thing where they, throw their head backwards and smash you right in the nose, and then your nose breaks. I don't know. And I actually know someone who this happened to, and she told me she had to go to the ER, and she was laying there in the ER, and they said, "We're going to find a plastic surgeon." And she said, "Stop. I've got my own." And she told me she called hers. This is actually in Houston. And he came. I don't know if he came over or if he just said, "Don't worry about it. Come see me tomorrow."
Yeah.
Is this something that's ever happened to you?
Oh, yes. Personally, I've been the recipient of the headbutt, and then I've had, and then I have, several patients that have come in. Nasal bone fractures are a very common thing that we see. The beauty is, to be honest, a lot of nasal bone fractures don't need to be managed. Even if you have a pretty severe fracture, a lot of times you don't even notice the millimeter, sub-millimeter movement of the bone. A lot of times we intervene on it mainly if there's a functional issue because it's hard to tell, especially with a kid hitting the nose and things like that. It's hard to get a severe fracture. Now, I do have a pretty extensive history and experience in managing facial fractures just in general. So I've seen all kinds of nasal fractures, from nasal bones looking like sawdust to kind of hairline fractures. There's a pretty wide array of management options.
So let's say hypothetically we've been coming to Basu plastic surgery for years, and now we know you're there and something happens to our nose. We can call the office now, and
Oh,
you're there to help.
please. I would love to help.
That's great. So we know you can take faces apart and put them back together for people of any age. We know that you are great at noses. What about secondary rhinoplasty surgery?
Yes. So secondary, we always kind of quote, or I quote when I talk to patients, that the revision rate after a primary or initial rhinoplasty is between 10 to 15%. So 1 in 10 people will possibly need a revision rhinoplasty. It's either they don't like the cosmetic result or they can't breathe well out of the nose. Now, when I look at revision rhinoplasty, the main thing that I talk about is the need for extra cartilage or grafting structure pieces to help rebuild and reshape the nose. Because typically, when patients have their initial rhinoplasty, a lot of the spare parts or the spare cartilage has been removed. So I talk to patients a lot about using their own rib, depending on the patient's age, on their specific concerns or comorbidities. The rib is a very nice piece of cartilage to use to rebuild the underlying structural framework of the nose, as well as use it for grafting to obtain the specific contour that you're looking for.
If you've just had a rhinoplasty and you are looking at yourself in the mirror and wondering, wow, how long is it going to take for me to look the way that I want to? How do you kind of set those expectations for recovery?
Yes, and I've learned this the hard way that you have to set the expectations early and you hammer it in. And what I mean by that is I tell every patient 1 week after surgery is when we take the splints off, the cast off, and it's going to be swollen. It's going to look nothing like what the final product will be. And you may even regret it as soon as we take the cast off because of the expected swelling. At 1 month after surgery, a lot of that initial swelling is gone. And when you're walking down the street, people have no idea you ever had surgery in your face. But when you look in the mirror, you're going to still say, oh my goodness, my nose is extremely swollen. Now, at 4 months after surgery, again, this depends on the patient's skin thickness and things like that. But at 4 months, most of that edema or the swelling is gone, and you get a really good idea of what the final product is going to look like. Now, technically, you're not done healing for 12 to 18 months after that initial incision was made. So again, depending on the thickness of the patient's skin, the strength and integrity of the cartilage, there may be little small millimeter changes as your skin kind of contracts down over the 12 to 18 months. But in general, most patients have a very good idea of what the final product will be or look like at about that 4-month time frame.
Does rhinoplasty often help people breathe better?
Yes. Quite often, I do a lot of functional plus cosmetic rhinoplasty. So priority-wise for me, number one is always function. You have to be able to breathe out of it. A close second is form or the way the nose looks. If the nose is this beautiful little thing on your face, but you can't breathe out of it, you're going to realize that breathing is your priority. A beautiful nose isn't beautiful unless you can breathe out of it.
We talked about your training and where you grew up. You're from Denton, which is Dallas, right?
Yes, ma'am.
Do you remember when you knew you wanted to be a doctor?
You know, that is a question you get along the way through every interview, through the basically medical process, med school, residency, fellowship, jobs. To be honest, I've always wanted to be a surgeon. I don't know when it started, but I love working with my hands and I love helping people. But to be honest, choosing to become a surgeon is much more selfish than my desire to help because I just really enjoy operating. I enjoy working with my hands. So I've always known I wanted to be a surgeon, but that instance when I knew I wanted to go to med school, it's just always been there.
Mm-hmm. I ask this question pretty much on every interview, and the answers are either like yours, like it was always there, or there's another one which happens all the time too, which is I was doing this other thing, and then they hit a huge wall of some kind, like some insurmountable blocker, and then they immediately pivoted to becoming a surgeon. And so some of those are like, I was a professional ballet dancer and I went skydiving and I broke my back. And the next day I applied for medical school.
Yeah.
That was one of them.
Well, that's a better story than mine.
I know, it's way more interesting than I always knew. And then yesterday I was talking to someone who said I was going to be a professional baseball player. And then the day he realized that wasn't going to pan out, he said, I'm going to apply to medical school. So it seems like there's a pattern. Like there's the doctors who always knew it. And then there's the ones who were high achieving in some other thing that abruptly ended. And then they just pivoted.
Well, that's interesting. I mean, I played football in college, and I remember my first day realizing that I was not nearly as good as the rest of the guys, and I had to have a backup plan. So med school is always there, and by playing football, it reaffirmed the fact that I needed to go to med school because I didn't have a future in football, that was for sure.
Pretty self-aware, too, if you knew on day one that you weren't.
Oh, yeah. To be an NFL football player, you have to be a special caliber. Yeah. And I definitely realized that I was not there.
Well, in Texas football, it's not like you're not a big fish in a little pond. Like, this is the pond.
Yeah. Yeah.
Are you board certified yet?
I am.
You are? Okay. Board certification is often misunderstood by patients, but doctors say it, like I'm tall, I live in Houston, and I'm board certified. Like we should all know what it means. And luckily I know what it means now, but I like to ask how you How do you explain to patients what it means and why is it actually important?
Yeah, so board certification it basically means that that physician or surgeon has met a certain standard within their specific field. Now, there's several different boards. You have a board of surgery, you have board of plastic surgery, American board of facial plastic surgery, American board of otolaryngology head and neck surgery. Now, all these are different groups that ensure that anybody that has gone through specific training has maintained a specific standard and understanding of that field. And I think it's extremely important that you research your surgeon and understand, number one, their training and credentials and qualifications, as well as their board certification. Because you're right. I mean, you can claim that you have any sort of board certification, but what does that mean? You need to know what board they're certified through and what they're certified to do.
And which ones do you have, just one or multiple?
I have one through otolaryngology head and neck surgery, and then I've completed the process through facial plastic surgery or the American Board of Facial Plastic Surgery. You have to be in practice for 2 years before you're allowed to get or obtain that certification. So mine's coming up this year.
That's exciting.
It's a process.
It is. By the time you get there, you've already done so much. It probably doesn't seem like, you know, you're just doing what you've always done. You're still going.
It is.
When someone comes to see you for the first time in person, what should they expect from that?
Yeah, they should expect to get to know me as a surgeon. I always introduce myself, explain my background. I talk about my wife and kids. I want them to know me as a person. Every surgical patient, I give my cell phone number. Some people say that's crazy, but for me, for patients, a lot of times, this is the first major surgery that they've had, especially when it's a cosmetic surgery. It's a little bit more kind of on the line because it is something that's not necessarily needed or required, quote unquote. So it's anxiety provoking for them to go through this process. Because again, it's a 12-month process from as soon as that incision's made until you're fully healed. So a lot of times they have questions or things, and I want to be able to I want them to be able to get a hold of me as easy as possible.
Aesthetic medicine goes through trends just like anything that's visual. And I, over the last year or two, maybe have seen this idea of natural come up all the time. I just want to look natural.
Mm-hmm.
And that word could mean so many different things to so many different people.
Yes, agreed.
So
It can be, yeah, and I agree with natural. I mean, and my definition of natural can be different to somebody else or than somebody else's, just like you said. So I really make sure I understand the patient's desires or goals on that initial consultation because I don't want there to be any ambiguity between my desired outcome and theirs. So
do you use any visual tools to help that process?
I do. I use 3D imaging software specifically for rhinoplasty because rhinoplasty, again, sub-millimeter changes can make all the difference, or the sub-millimeter desires are hard to articulate for some people. So if you can get a nice 3D image, both of us will be on the same page. Facelifts, I do have 3D imaging that I use. Sometimes it's hard to get that desired outcome on the current technology, but doing a lot of tissue manipulation in clinic, in the mirror and things like that can show you really what sort of goal or what sort of outcome we can achieve.
Do you ever run into someone who you just cannot align with their vision and you have to say, maybe we're not a good fit?
Yes, because I don't want to operate on somebody where I don't think that I can give them their desired outcome. Whether that's a reoperative face or nose, specifically with the nose, I think that you see that a lot more, or I personally see that a lot more as a facial plastic surgeon. Patients will be on their third revision rhinoplasty and they have really thick skin, but they want this tiny little nose. And for me, that's not something I can do or give you. And the risks are a lot higher when you're, doing a revision. So those I'm very weary of, and I try to be completely transparent with patients Because like I said, this is a year-long process. And if I operate on you, you and I are kind of stuck together for at least 12 months.
Noses and chins. Someone described this to me once as they have a signature look.
Mm-hmm.
And I think one of the things that, not commonly, but sometimes happens is you have a nose or a chin that looks like everyone else in your family.
Mm-hmm.
And if your idea of what that should look like is either to continue looking like everyone in your family or to look nothing like everyone in your family,
Mm-hmm.
that might not always be the exact same thing as what an aesthetic result may look like, in a magazine. But I would never change my chin, even though other people might look at me and say, I could do a lot with that chin because
Mm-hmm.
I look like my grandmother and I look like my cousins and I look like my mother.
Mm-hmm.
And
I
I
get
don't want
it.
to not look like them because I love them.
It's part of your identity, you
Mm-hmm.
know, and I get that very often, especially with humps, dorsal humps, or on the bridge of the nose. A lot of times, people, for functional reasons, they want to straighten the nose. They want to soften that bridge or that hump, but they don't want to completely get rid of it because you're right. Their dad has the hump or their mom has the hump. They want to improve the contour a little bit, but they don't want to completely get rid of it. And that's honestly why I love the 3D imaging, because we can really pull that down, and they can specifically tell me how far they want to bring down that hump. Because when somebody walks in and says, take the hump away, for me, I understand that completely different than somebody else that says, I just want to take it down a little bit. So you're right. I mean, when we change the nose, it can really change the face. And you don't want to look like a completely different person, maybe just a more refined version of yourself.
Exactly. Well said. What other procedures do you love to do?
So rhinoplasty and facelift are really kind of my favorite. One that I like a lot and I've been doing a lot more of recently is just a deep neck lift in younger patients, 30s, early 40s, where you're not removing a lot of tissue or anything, but you're just improving the contour of the neck. And I'm sure you know this or heard this, especially in the Zoom era. Everybody's looking down at their phone or on Zoom and realizing, whoa, where is this double chin coming from? So you're starting to see a lot of these younger patients come in, and you can do amazing things to the neck with one small incision, just removing a little bit of the deeper soft tissue and sewing some things together and really improving the contour.
There is a less expensive way to do it, though, Dr. DeBusk. You just move your webcam up higher and
Yeah.
point it down at you.
Hey, you know what? I think you're onto something.
I've been doing that for years. Another trend is that buccal fat pad removal procedure that's been
Mhm.
flying around this year. All of a sudden, everyone knows what it is and is talking about it. We don't have to beat that dead horse, but are there other little tiny procedures that you think have a big impact?
Yes, I think that like anything, these fads come and go. Because years ago, so in my training in Minnesota, Dr. Peter Hilger is pretty well known in the facial plastic surgery world. His father was one of the original founders of the American Academy of Facial Plastic Surgery. So with him and his family, I mean, he's seen every fluctuation and trend. He's seen everything go and come and go. So he's not a big fan of the buccal fat pad removal. It kind of instilled that in me. My point in saying that is that, yes, you see these fads, everything kind of fluctuates. But another big thing is the lip lift. And I think that we've all heard of that, seen that. Apparently, that was something that was desired back in the day. But I think that it does give a good rejuvenated look or appearance in the right upper lip. Because as we age, just like gravity affects everything else in the body, it does elongate that upper lip. And I think that a lip lift, which is a pretty minimally invasive procedure, I mean, it is removing skin, but something that I do in clinic. It's a pretty quick, easy procedure that can give pretty good and lasting results.
What's the recovery like for that one?
Yeah, so like anytime we make an incision, again, that first week you're going to have a lot of swelling, some redness in the incision. I do a subnasal lip lift, so it'll be a little red line right under the contour or the shadow of the nose, But again, once you hit kind of that 3 to 4 week period, all that initial swelling's gone, that scar's pretty much faded. And given the location of the scar, once you're completely healed, it's virtually invisible.
Can you do eyelids in the office too?
Yes. So that's primarily how I do upper eyelids. An upper blepharoplasty is in clinic. Takes about 30 minutes operative time. The eyelid skin is extremely thin, so you do anticipate some dramatic swelling the first couple of days after surgery, but that's normal. Again, 1 week after surgery, it's still pretty swollen, and then once you get to that 1 month time frame, you get pretty dramatic improvement in that initial swelling. But the upper eyelids, I mean, it's a relatively small procedure, a blepharoplasty, but it can make all the difference in the world. Make people look more rejuvenated, awake, less tired.
What about the lower eyelids, the eye bags, the dark
Yes.
circles?
I do lower blepharoplasty. I'd personally like to do that in the operating room just because it's a little bit more invasive and there's a little bit more involved with manipulating of the fat of the lower eyelids. But we see it a lot. I mean, the tear trough filler has become a huge thing. A lot of people are interested in it. A lot of people get it. And there's a lot of people that have complications because of it. Because your injector has to know where to put the filler, how deep, how much, in order to really alleviate or minimize that tear trough. But it's a temporary solution. And as you age, it only gets worse. But a lower blepharoplasty or manipulation or repositioning of the fat of the lower eyelid is a permanent solution. And it gets rid of those tear troughs.
So, okay, really important question. Cowboys or Texans?
Oh, Cowboys.
Oh,
So I
boy.
know it's a cuss word down here in Houston, but being originally, from Denton, Texas in the 90s, I mean, the Cowboys were everything. So I still, even though they still break my heart every season, I still have to pull for Jerry's team.
Okay. I predict a rivalry in the office. It's
I
coming.
know it's a big Texans office.
Yes, it is.
I may I may have to keep my mouth shut, I think.
Depends. I mean, it sounds like you're not too afraid of controversy. So, if you want to go there.
I'm a bigger LSU fan, to be honest.
Oh,
Oh yeah.
yeah. I think you're going to be okay there because they're Tigers and Princeton is also the Tigers. So you got two Tigers.
Yeah, it fits nicely.
You'll be all right. And if anything, your shared love of football will keep you together and happy for many, many years to come. Obviously, most people know surgeons can't do everything by themselves, and the team around you is as important as the surgeon themselves. How do you think about your team and how they are there to support the patients? I know you probably don't know them all yet, but maybe in
Mhm.
a general sense.
Yeah, I mean, I think the team is just as important, if not more important than my role, to be honest with you, because I mean, they're the ones that are constantly in contact with the patients. They kind of set the expectation before they even meet me. And, they are the face of the practice, the team is, because they, like I said, they are the ones that are really interacting with the patients, discussing the pre-op, the post-op, seeing them more often than I am. And you can't do it alone. And I've learned that in my first year of practice where, I was doing the majority of everything, from contacting, price quotes, everything, photos, all my own, everything. And it's overwhelming. And you can't do it all yourself because you will drop the ball somewhere. And I've really learned to appreciate the team and really now understand the importance of the team because they do come first.
How do you think they would describe you, or at least the team you have now? How would they describe you?
Easygoing. I think that it takes a lot for me to get flustered. I think I'm very relaxed, kind of go with the flow kind of guy. I do have high expectations for my outcomes and for my patients, but overall, very relaxed, easy to get along with. Joking in the office. I think in the office should not be a sterile place. I think you need to have good relationships with everybody, very collegial across the board because I like to have fun. I want to be in the office. I don't want people to want to leave, to look at the clock and can't wait to get out. I want people to enjoy being around me and around the team.
Is there anything you want listeners to know that we didn't cover yet?
So I am also a clinical assistant professor at the University of Texas Medical Branch, teaching head and neck surgery residents and plastic surgery residents, doing a lot of rhinoplasty, skin cancer reconstruction, trying to develop more of the facial nerve as well in the microvascular department and things like that. But I do love the education. I love interacting with trainees. It's fun. It's enjoyable. Can be frustrating, but that's also the fun part.
Yeah, going to Galveston is always frustrating.
Yeah.
Where can we find out more about you?
Yeah. So DeBuskMD.com. And then soon my profile and things will also be up on Dr. Basu's website. And then I have an Instagram account, and it's just Dr. Taylor DeBusk.
I will put all of that in the show notes with links. DeBusk is DeBusk.
Yes, ma'am.
Thank you so much for sharing your stories with us today.
Yeah, no, I appreciate your time. This has been a good experience.
If you're considering making an appointment or are on your way to meet this doctor, be sure to let them know you heard them on the Meet the Doctor podcast. Check the show notes for links, including the doctor's website and Instagram, to learn more. Are you a doctor or do you know a doctor who'd like to be on the Meet the Doctor podcast? Book your free recording session at meetthedoctorpodcast.com. Meet the Doctor is made with love in Austin, Texas, and is a production of The Axis, TheAxis.io.